with that, Dr. Tal Morr.
Can everybody hear me? Good afternoon, and I'm glad you're all here after lunch. I know it becomes a little bit tiring. I want to thank the Academy. It's truly an honor and a pleasure for me to be here. I want to thank the Academy for giving me this invitation so that I can spend the next 45 minutes with you on a topic that I think is very important. When a patient like this presents to our office and they have functional and aesthetic concerns, they want to look better, but they also want to function better because they're wearing down their teeth, they have broken down restorations, and you have to figure out how you're going to restore this patient. This is where you have to ask yourself, how do I begin? And really, it's the integration of aesthetics and occlusion that's the key to developing the treatment plan for these patients, because aesthetics is really the guiding force or the driving force for us in terms of how to rebuild this patient occlusally. And if we follow a specific step-by-step protocol for each and every patient, generally the result is predictable both aesthetically and functionally. So that brings us to the topic of today's lecture, which is aesthetic and occlusal integration in the complex restorative case. So we're going to talk about how aesthetics dictates to us how we're going to rebuild our patients aesthetically. And we're also going to talk about how we ensure that everything is based or transferred down the line throughout the process. When we think of these complex restorative cases, they're generally treated by a team, that consisting of the restorative dentist or prosthodontist as well as the laboratory technician. The more complex the case, the more people are involved in the case. It could be an endodontist, an oral surgeon, maybe a periodontist, and even an orthodontist. The more complex the case, the more chance for error. The more chance that something is going to go wrong. So that really the key to success in these types of cases is the ability to transfer information throughout the process. And when I say transfer information, I don't mean verbal information. I mean physical information that everybody can use so that there's no question as to the final outcome. So where do we begin in treating these patients? Well, as I said before, we're going to use aesthetics as our guideline or our direction in terms of how to treat these patients. So what I thought I'd do is go through the aesthetic evaluation, but only the critical points which I think are important in treatment planning these patients. We always begin by looking at the face and then working our way inward. And the first thing we need to do is pick a horizontal reference plane. Now, there are some common horizontal reference planes such as the interpupillary line, the ophreac or the eyebrows, and the commissure line. And unfortunately, most patients happen to be asymmetric. And so what I'll do in my office is I'll actually use the floor. I'll have the patient look out into the horizon, use the floor, and pick 2 points on the face that are going to give me my horizontal reference plane. Hopefully, one of these fall within that parameter. The next step would be to create or determine a vertical reference plane. And generally, that's the facial midline, which is a line bisecting the philtrum of the lip or the middle of the face. Now, what's important here isn't that the teeth fall exactly in the middle, because we know from the literature from Vince Kokich Jr., you can be up to 4 millimeters off and still have an acceptable aesthetic result. The issue is more on the verticality of the midline, and we're going to talk about that a little bit later. Facial proportions is also something we need to look at. There are 3 portions. What we need to focus on is the lower 1/3 of the face, because that's the area that we have the ability to manipulate and change. So if the lower 1/3 is short, we may want to consider opening the vertical dimension to improve the profile. And if it's long, you want to be careful, and if you need to reposition the teeth or create room, you may want to consider orthodontics as a treatment. Facial profile is also important, not the numbers really, but the fact that there are 3 types of facial profiles: the normal, the convex, and the concave. And what's important here is that we know that for a normal patient, we want to make sure that we don't alter the position of those teeth, so we don't alter the facial profile. That would be a horrible thing to do to a patient that looks good. While if they're convex, we may want to consider procedures to bring the teeth in, and vice versa if they're concave. We want to bring the teeth out maybe to improve the facial profile. So now that we looked at the face, let's focus in a little bit and look at the relationship of the teeth to the lips, because this is our starting point. The first thing we look at is the incisal edge position at rest. And generally, there's a range of acceptability in aesthetics. It's anywhere from 1 to 5 millimeters. Females show more than males. Young people show more than old. And the beauty of the incisal edge position